My name is Indy. I'm going to talk about angina pectoris or angina pectoris, sometimes referred to as stable angina. It is chest discomfort that's caused by myocardial ischemia. It happens when the demand on the heart, the oxygen demand is higher than the oxygen that's actually being supplied. And something to note is that the quality, duration, and the causative factors of stable angina are predictable. It's based on the heart rate, the systolic blood pressure, the muscle wall tension or stress, and contractility. Who is at risk? So we have modifiable and unmodifiable risk factors. It's all your classics. You have your CAD, hyperlipidemia, tobacco use, hypertension, obesity, metabolic syndrome, stress. Then you have your family history of cardiac issues, African American race, male, and postmenopausal females catch up to male risk once they hit menopause. Three questions to ask when you're trying to diagnose angina pectoris is you want to know about the quality of the discomfort. There's going to be characteristics of the pain that are typically not going to be sharp or stabbing. They're not going to be able to localize the pain. It's going to be more diffuse. It's going to happen in the same spot usually, and it'll have a gradual onset and offset. You want to know the preceding factors. Typically, it's going to be anything that increases O2 demand. So your discomfort or their discomfort will increase with activity, maybe cold, sexual intercourse, sometimes with meals, and relieving factors. They're going to be improved with cessation of whatever the precipitating factor is. And their timing is typically going to be 2 to 5 minutes. Anything longer than that or that does not meet this criteria, it may be something else like reflux, pericarditis, pleuritis, and then also anxiety and panic disorder. Top three PE findings. So typically in physical exam, it may be a normal exam. They might have tachycardia, and then they also might have a murmur, either new onset or a change in an existing murmur. You may also see Levin sign. That's when they clench their fist over their chest. That is a classic finding. Diagnosis and treatment. It's basically going to be based on your your physical exam and a thorough patient history. You can do a workup to rule out anything else, as mentioned above. So you can do your EKG, echo, CT, or X-ray. You can also draw some labs like CMP, lipids, and troponin. Modifiable risk factors are your number one treatment, but also abortive treatment like nitroglycerin and cardiac medication like beta blockers, calcium channel blockers, and ACE inhibitors, especially if they have hypertension. Teaching, you want to teach them about their modifiable risk factors and how to improve those. So, a well balanced diet, increase in exercise, and making sure that that exercise is tolerated. In the meantime, you want to teach them about follow up. So if they have follow changes in frequency, severity, or pattern of their pain or discomfort, you want them to come in because they may need a brand new workup. When to go to the emergency room, any onset of heart attack. So if there's no improvement in the discomfort, if they have jaw or arm pain, I'm going to have a whole new slide on that. And then you want to teach them about their cardiac medication, mainly that they are not to stop taking their medication abruptly and without medical direction. You also want to teach them about their nitroglycerin if you prescribe that. It can be a dissolvable tablet under the tongue. They come in ointments or sprays. If we talk about the nitro tab that goes under the tongue, that will they will take that at the onset of symptoms and then every 5 minutes for a maximum of 3 times. If that does not help, they are to call 911. And then when to call 911, if pain is onset severe, if they're having shortness of breath, if it lasts more than a few minutes, if it gets worse, and anything that scares or worries them. And these are my references. Thank you.